We are approaching the end of the day, which was very stimulating, and again, I would like to thank the organizing committee, local and international, for giving us this opportunity to share so many interesting points and issues. And the end of the day is the discussion of the end of life. So everything comes to an end. I was thinking when I got the assignment, what can you do on such a topic with so many participants in a half an hour and an hour? Here in Israel lately, a law was legislated on the dying patient, and it took 5 years of long and heated debate. And even after that, I'm not sure that everyone agrees with everything that is in the law. So certainly in such a short period of time to cover such a topic would be impossible. I would like to start by leading the discussion into more principle and ethics issue rather than going into the details, because I'm sure that if we'll discuss details, no one here will agree to everything, and we'll start with the difference and we'll go back with the difference, and I don't think we'll gain much. But if we'll try to conceptualize what the issues are, or at least some of them, maybe we can come out with some framework. And I would like to suggest two topics to make two rounds amongst the panel and then open it to the audience. First is definitional. Who are we talking about? Who are the candidates for end-of-life decisions? As you know, everyone that was born starts the process of dying. And we really die the moment we are born. At some point, we call it end of life. But what is this point? Can we define it? And if yes, does it make such a fundamental difference between a moment before this definition and a moment after, or is it something gradual? So I suggest we should start with this question if we can get some answers to that. And I would like to exemplify it. We are talking about neurodegenerative diseases. ALS, Alzheimer, Parkinson, all start at some point and we know what the end will be. Yet, do we define a person entering end-of-life decisions the first time that he forgets his wife's name, or can we wait a little bit and maybe he still has a quality of life or a chance to live, and only in 20 years will we start talking about end of life? And why then? Or we can take an ALS patient who starts to have some weakness in his arms, some tingling, and we know that at the end he won't be able to breathe. But where is the point that we will call him entering the end-of-life process? So I would suggest to start with this. There are some definitions from a legal, religious, and ethical point of view. I'm not sure that everyone would agree, and I'm opening it. Maybe we'll go from left to right, not politically oriented.
Okay, some very interesting and I think very challenging issues on a very, very difficult and contentious topic. I think for me, end of life has to be thought of in terms of, or certainly associated with, quality of life. And I think if we're thinking, for example, somebody who has a dementia, whose cognitive abilities are decreasing over a period of time, maybe quite a long time, depending on whether that's older onset or younger onset dementias. We need to think quite carefully around at what point is that person's life not of good quality, and the level of autonomy and personhood they have in relation to those kind of decisions and choices. And I think for many people, the diagnosis of a degenerative illness is actually not the point where they want to be thinking about the end. It's a process, and a lengthy process. for many people. And the difficulty is at what point those conversations should be had. And I don't think there's any fixed decision around when that could be. I mean, you can meet some people who have Alzheimer's disease or dementias who are verbally very competent for quite a long time and show a great level of insight into their condition. For others, their communication skills will deteriorate very rapidly. And of course, we don't know a priori when that point might be. So I think it's about having some difficult conversations fairly early on. And that's with family members, with familial caregivers, with service providers, with people offering care, in order to facilitate people expressing their views and their opinions about what they may want. But of course, as we've seen in the case studies, some of the case studies we've been provided with, what people want at point A isn't necessarily what they want at point B, which again throws a great deal of uncertainty and difficulty into the ring.
Just a clarifying question. You emphasized the point or the addition of quality of life. Can you define it?
Lots of people have attempted to define it. Often it gets boiled down to tests and scales, like, for example, the activities of daily living scale. So if you can dress yourself and feed yourself and wash yourself and get out the house, those are the kinds of things that are seen as indicators, proxy measures of quality of life. But of course, again, that's incredibly thorny, because actually the activities, daily activities that you can engage in actually might be quite limited, but you still have a sense of well-being, a sense of engaging with the world and taking value in the things that you can do. So even something that's often boiled down to quite simple, tick sheet style questionnaires is a really complicated and difficult task to work out.
Okay, thank you.
From my psychiatric point of view, I just want to say that the decisions about end-of-life capacity of making decisions, many of the elderly develop cognitive decline. However, some of this cognitive decline usually caused by depression, where depressed people often feel that life is not worth it, and this is the reason that they try to or succeed in all the suicide attempts. I just want to add the point of that some of the end-of-life decisions should be taken after the patient was going through a cognitive and psychiatric evaluation to make sure that his decisions are not just because of depression that we can treat.
Okay.
Hi. This is, I guess, outside my area of expertise, and I'm pretty ignorant of the Israeli debate that has been going on here, led to a law. So to discuss this question, I think there are probably no recipes on when this should be appropriate to discuss. But there are probably common ingredients that make up different solutions or responses to this topic and issue. One thing that was brought up to our attention in the last talk is actually knowing the patient. This is a challenge. I think for clinicians to really meaningfully engage in conversations with the patient and caregivers, they need to know their patients. They need to know them and to get to know them. Ethics has to be part of the process. So we need to acknowledge the role of ethics and the importance of ethics in the discussion. And likely the process needs to be interdisciplinary, involving different expertise, psychiatric evaluation, social work, ethics, and of course neurological care. So my response is, it's very hard, I think, to respond in a general way to specific cases. I think clinical ethics is really a case-based approach where there are no recipes, but there are likely common aspects to cases that need to be taken into account. And I suggest that knowing the patients, ethics being acknowledged as important, and interdisciplinary approaches are some features.
Okay.
Well, this is clearly a very difficult issue and a very individual one. And I would assume that for different patients, even the difficulties of having to deal with the experts are a problem. At least I know that from my late mother's experience, where when she was confronted through a discussion with a geriatric specialist with the fact that she didn't know what year it was or who was the prime minister, she was in a real crisis. That was probably the toughest experience for her, whereas before she was protected by the family, saying, you're just tired, you rest a bit and you'll be all better. And it is a problem also for the family, because, again, I know from the same case that I would come to the home where she was hospitalized to feed her, and people would look at me and say, aren't you the daughter? Aren't you a brain researcher? As if, this was something I caused. So that
you
is...
could cure.
And I hope I would. So this was one case. But then again, I would like to join Dr. Pill in saying that the extent of neurodegeneration is also a very important component. And again, from my own experience, my late father-in-law was 94 years old, and he suffered a pulmonary insufficiency because his heart was failing. And the doctor said, so now we need to confront him with a psychiatrist because we need to define him as incapable of making decisions because he has a short-term memory problem. And by and large, we got through a discussion to the agreement that they could intubate him without total anesthesia, and then they don't need to confront him with that very unpleasant experience that his power to decide on his own life is taken from him, which pleased him a lot. So they treated him, and he got a little better for a little longer. And I remember him looking at me and saying, oh, that's good, so now I can go back to my old life. He was 94 years old, and he was certainly at the neurodegeneration path. But this saved his dignity for a little longer, and he definitely wanted to live on. So it's a very individual case. That's all I can say.
Okay, thank you. I'll try to pinpoint a little more what I intended in my question and open this question to the audience if you have anything to say on the question or on what was said here. What I intended was to try to understand when do we implement decisions of end of life. It is one thing to say that I personally would call myself in an end of life situation the moment I can't give a lecture in this audience. And it is another thing to say that when this stage comes and I have a pneumonia, no one will intubate me. So the question is, can we define a situation where we can implement decisions of end of life, which means either not to intervene or to withdraw treatment or to euthanize, depending on the various cultures. And for that, we need a definition. It's easy for us here to say, we'll take into account the quality of life, we'll take into account our personal experience, we'll take into account individual people, we'll take into account clinical ethics. This is all good up to the point where we have to make a decision. And that is where legislation can't afford to say, give everyone his decision-making capacity, whatever he'll decide will go with him. We'll go to this question, maybe this is a solution, but we'll come to it, I think, in the next round. how do we make policy decisions based on ethics. But I think that the first question when we deal with end-of-life issues is not only how do I define my condition as an end-of-life situation, but when do I implement decisions that are different for end-of-life than for non-end-of-life decision. And that, I think, was one of the major issues that we struggled with in defining the law here in Israel. We came up with a solution which is problematic because we try to get to as wide a consensus as possible, and therefore we had to minimize the definition. But the question is, can we do it better? And so far I didn't hear a better solution. Anyone in the audience who would like to take a stand on that or to comment? Yes.
I was wondering, when patients are hospitalized, they have to sign a certain form, and would it be advisable to have a on the form or on the questionnaire a C for sort of an article that if something happens to me, I don't want, or I do want to have a life support and so forth. And if you can maybe comment on the fact that there are quite a number of people that are hospitalized for 10 years or more, and they're called brain dead, but they're still on machines and so forth. And of course, this is a lot of money, and costs the government a lot of money. And what is the solution? And last, on this form, would it be appropriate to also have, and if something happens to me, I also give my consent to have organs available for transplantation, because in many countries, automatic, like in Belgium, everyone's, after death, the organs are available unless the person says, I don't want. Thank you.
Okay, I think you asked one question with many subdivisions, and I think it will take us more than one conference to answer your details. Just in principle, there is what is called Advanced Medical Directive that I think everyone here, certainly the Israelis, should do it now when we are still, I hope everyone here is competent enough to fill out, even at that late hour of the day, to fill out such a form. It's an official legislated form that you can state what you want to be done with you or not be done with you when you reach the definition of end of life, which the Israeli law is very limited definition, but I think everyone should do it, because when time comes and the decision has to be made, most of the people, not all, but most in end of life are not capable of making their own decision. And hence the law here, in many countries, it's not maybe legislated, but it's ethically advocated that people should state what they want to be done with them when they will be incapable to make their own decisions. So that is one thing that can be done. Second thing is, when a person becomes ill, now hopefully we are all healthy and we don't go into any type of definition of end of life. But once we are sick with a disease that the prospects are not good, then again we should reconsider if we wrote an advanced directive or write it then. Now the reason to reconsider is that statistics show that about 30% of people change their minds, and they change it to either direction. Some, when they are healthy, think that only if they can play football, that's what's worthwhile living, and when they reach an old age, they want to see the bar mitzvah of their grandson or something like this, and they want to live longer. And others say, I would like to live as long as I can, but once they get there, they would like to live shorter. So there are changes, and therefore people should reconsider it when they get really sick. But that is beyond the question that I posed. Let me tell you what the Israeli law decided. The Israeli law distinguished between a process of end of life and a situation where survival, not quality of life, but actual survival is limited, which is easier to define. It's easier to say that if I am expected to survive, good or bad, less than X weeks, months, or years, that is an end-of-life situation, and then we can apply what we want, as opposed to someone whose survival is expected to be very long, but the quality of life in those years is very low. Because to define on the second example, on the scale when the minute of end of life enters, is almost impossible. And it's very individual, as was said here, and therefore, as a legislative measure, it was impossible to reach any kind of a consensus. So the Israeli law defines a dying person as someone who is expected to die within 6 months, which is accepted in the Dutch legal law and in many other countries, which talks only about survival rate and not about quality of life. So in other words, if someone has Alzheimer's disease and he is deteriorating, but medically, physically, he can live another 10 years, he is not qualified to the law of end of life, because we don't know where to put him at a particular moment. There's another issue with quality of life, and this is who says that someone who is severely demented has a bad quality of life? The ones who say it are we who are not demented. But who says that he doesn't have a good life? Why should he die? The same holds true for a persistent vegetative state. If he is without any pain, without any acceptable suffering, who is suffering by the fact that he is still alive? The only one who suffers is his spouse or his son or his daughter. But is this a reason to let him die? So there are a lot of very deep questions on how do you define end of life based on quality of life. But it is easier to define it based on survival and on pain and suffering. Because everyone agrees that unbearable pain and suffering is something that no one wants. But to be demented, we don't choose it. But once we are there, who knows if it's good or bad? Maybe it's better than having all the trouble that we have when we are aware and conscious. We don't know. So that is a question. It's an open question. Now let me move to another set of questions. And I want to discuss, if time permits, the basic ethics on end-of-life decisions. On the one hand, the accepted, although some people even reject that, but the accepted notion is that the default is to live. People want to live. And we know it from experience that people, even in bad conditions and under great stress and trauma, and they fight for life. People want to live. But do they want to live at all costs? And do we as a society want to extend their life at all costs? That is really the question. And I think from an ethical point of view, we can consider, we saw here the mantra of Georgetown, all four or maybe more ethical principles, and certainly apply them to end of life. But I think that talking about beneficence, for instance, which is a very important prima facie ethical principle, is useless in end-of-life situation. Because how do you define beneficence in a dying situation? Is living a benefit, and therefore no matter how it's beneficial to continue living, or is beneficence dying in such a situation and therefore we should kill the patient? So beneficence is a very problematic thing because it depends on who defines what the benefit is in this particular situation. Same holds true for do no harm. Primum non nocere was really the first and the most prevalent ethical principle since Hippocrates. But what does it mean not to harm in end-of-life situation? Is it to let him live? Is it to kill him? Is it to avoid treatment? Is it to withdraw treatment? How do we define it? So it's a definitional problem, and I don't think it's very helpful in clinical situations. to me at least, the two sets of questions are the value of life and autonomy. And I would submit to you that if we can make an ethical decision in extreme on either of these principles, we don't need this panel anymore. In other words, if we would say that the value of life is an absolute value, there are no exceptions to it. The same way as I treat a 20-year-old person who has pneumonia and I give him all the treatment in order to cure him, the same way I have to treat the 94-year-older with his pneumonia, put him on a respirator and keep him on the respirator and prolong his life with whatever it takes. Because the value of life is infinite. You can't say that 50 years have a value and 1 year doesn't have a value. In other words, where do you put the border of the value? If it is limited by time, then what would you say? Someone who can live 6 months is not worth living. But if he can live 8 months, it's worth living? If he can live a day, it's not worth living. If he can live 50 years, it's worth living? No one can set such a set. Therefore, one can assume that the value of life is infinite, and therefore we don't have to argue on anything. We have to treat everyone as long as we can, no matter what. That's one extreme. The other extreme is take autonomy as an absolute value and ask the patient, does he want to live or doesn't he want to live? And whatever he tells you, do it. So here, what will happen if someone gave all his money to Madoff and he lost all his money? And now he is desperate, he doesn't want to live anymore. And he comes to the doctor and says, I want to die now, I can't live anymore. If autonomy is an absolute value, who are you to judge why he wants to die? He wants to die. To him it's terrible. To him it's worse than having Alzheimer's or cancer. So where do you set the limit on autonomy? Can you say, if a patient comes and says, I want to die, then you'll make a judgment, your own judgment. Is it worth dying universally, and therefore I'll accept his autonomous wishes? Or I think it's not worthwhile dying in this situation, and therefore I'm not accepting his autonomous wishes. So if we would go to the easy way and say, whatever the patient says, that's what we'll do. So I think we can go in hospitals with pistols, and everyone who comes and says, I'm sick and tired of living, will shoot him. Why not? That's autonomy. We are helping to fulfill his autonomy. So taking these extremes, I assume, but I'm willing to open it to the audience and to the panel. Is anyone thinking that ethically speaking, from a principal ethical point of view, either the value of life or the principle of autonomy is an absolute value? Whoever thinks one of these two can leave the room because he solved the problem and he doesn't need to hear us anymore. But as far as I know, no one thinks that way. And it's very difficult to explain why. I mean, if you are a proponent of life or a proponent of autonomy, who are you to make limits? Why do you make it? But I think we are smarter than ethics even, and we know that life is more complicated than an ethical framework, and we know that we can't live by absolute principles. Kantian theory is good to give a lecture in a hall. It's not good enough to live by it. You must make balances. That's all what ethics is about in an applied manner. So if we accept, and here I am opening again to the panel, if we accept that neither the value of life nor the principle of autonomy are absolute values, but they are important values, how do you balance between them? Where do you draw the line? When do you say that the value of life is more important than what the patient wants, and therefore I'll continue keeping him alive? And when do you say that autonomy is more important than the value of life, and I'll either kill him or let him die or do all kinds of end-of-life decisions that will shorten his life expectancy? I think this is, from an ethical point of view, the real question. There are other issues that come up, such as allocation of resources. We can open it to a wider discussion, but I would suggest, first of all, to see if we can come to any kind of definition. Where do you draw the line between value of life and autonomy when they oppose each other. I mean, if someone comes and says, I want you to do everything for me to continue my life, then the two values come together. Then there's no opposing issue. Then we come to other issues, scarcity of resources and so on. But at least within the two parameters, we have a clear answer. But what happens if someone says, I don't want to live anymore, which goes against the value of life, but this is his autonomy, and he wants to die now? How do we do it? So I think this is one of the questions that we have to answer, and different cultures and different legislators have answered it differently. And maybe we can start again from left to right and see how we approach this question.
Okay, I think what strikes me around these concepts, particularly the concept of autonomy, is that it's a concept that for those of us who live in rather individualistic cultural frameworks, it's something as a concept that we are very invested in. And I understand that. I think if we are thinking about end-of-life decisions in a neurodegenerative context, those concepts become shaky at best. If a person has no autonomy, that person isn't able to articulate their needs or wishes or wants, if they are unable, if they don't have a sense of personhood that we can identify as either healthcare professionals or familial carers, it puts autonomy as a concept on a very, very shaky foundation. And when you talked about advanced directives, which, you know, in an ideal world, they do solve problems when we're coming into this tricky terrain. But I think to go back to a point that I raised earlier, which is around when you have a diagnosis of a degenerative condition which will kill you, which is untreatable, and as Dr. Itan was saying, that's conflated with depression and all sorts of coming to terms with what's happening to you, which will potentially impair your ability to be able to make anything that we would see as a rational decision. And, you know, time goes on, degeneration continues, cognitive impairment gets worse. And if those checks and balances aren't put in place around autonomy, then who are you depending on? You're depending on familial carers, somehow knowing what your needs might be. You're dependent on your healthcare providers. And I think this is where resource allocation really does come into the fore. I mean, in the UK, we have a distinction between social care and health care. Now, the state, through the NHS, will pay for health care, but the state does not automatically pay for social care. Certainly not in England. It does in Scotland. It's one of these kind of complex things. So you have this odd kind of differentiation between those two kind of positions, which means for somebody who has a dementing illness, when what they primarily needing, certainly in the early days, is personal care, they're having to pay for that. And families have to argue very, very hard to get the state to support care for their relative. Now, if I give you a personal example, my father has dementia, and he's 63, and he's had it for 9 years. And he can't speak, he can't read, he can't write. And at some point, because of his age, he's not going to die of something else. If he was an elderly person, he would, you know, have a heart attack or a stroke or something like that. But because of his age, he will die of the dementia, and at some point, his swallowing reflex will go. And that's not a choice. You know, that I don't actually know where that choice will fall, whether it will be healthcare providers or whether it will be the family, but it certainly won't be the individual because they don't have the autonomy.
Well, let me sharpen the issue so that we'll stay on an ethical discussion rather than on a practical discussion for a minute, because if we want to really define the situation for the more complicated real-life situations, we have to be clear with basics in ethics. Let's assume it's an ALS patient who is totally competent. He is not affected at all cognitively. And he is in an early stage. And he understands where it goes to. And he knows that within half a year he'll need to be intubated if he wants to live, or he'll suffer from suffocation if he's not being intubated. And he says, I don't want to live even this half a year. But he's not going to die from anything unless you do something. Now, is autonomy a principle that can operate in these situations? In other words, can he demand from society, who are you to tell me that I must live this half year? I want to die now, which is accepted in many countries as a manifestation of autonomy, which is called active euthanasia in certain countries, which respects the principle of autonomy, overriding the value of life to the degree that you're actually taking a life which need not be dying now. Now, if you don't accept it, which most countries don't accept it, why and where do you set the limits of autonomy? Why only up to this point and not to another point? What will happen with physician-assisted suicide? What will happen with withdrawing of a life support treatment which life is dependent on, which is an active measure that shortens life? What about food and fluid? I mean, that all will follow if we define where the limits of either autonomy or life come to. It is true that when a person becomes already in an advanced situation where he has no autonomy, he stops to be an autonomous agent. But that is the second stage to discuss. What do you do in this situation if you are an advocate of autonomy when there is no an autonomous agent? In my field, I'm a pediatric neurologist. I deal with children who have neurodegenerative disease, who were never competent and who will never be competent. They don't even have the advantage to ever before say what they would have wanted to be. I have newborns who are born with deadly diseases, and they never were capable or competent to say what they want. And who knows what this person would have wanted if he would have been at some point competent. So that is a decision-making different than we are discussing now. This is a non-autonomous agent. Who makes the decision there would be a second level of discussion, which I don't know that we have time. Who makes the final decisions? But let's stay at a situation where autonomy is available. It's an autonomous agent. He asks for something which for some people makes reason, for others not. Why? Because it has to do with life, with the principle of life. So where do you put the border and why? That, I think, is something to discuss.
So from my experience as a psychiatrist, that some nights most of my work is just trying to talk with people who just try to commit suicide or just attempted suicide, or people who have many death ideation, and I have to decide whether I can send this patient home with respect of his autonomy, or should I hospitalize him in a psychiatric department so that we'll be able to treat the disease, I think, that caused these death ideations. And for this, I'll give you an example. I was called one night to one of the departments of internal medicine at Hadassah to meet with an old lady who had a few days before she was told that she has breast cancer. 3 months ago, I think, his sister died from the same disease. She came to the emergency room after she took about 100 of her usual pills, and she told me that she really doesn't want to live anymore. That she worked through with all the she went through all the stages of this breast cancer disease, and she doesn't want to have the same pattern as her sister. I mean, this was a very rational decision by her, and I was asked can you take her to the psychiatric department just to take care of her, that she wouldn't die? In such cases, the psychiatrist has some very defined rule by the government. If a patient is in non-psychotic state, I mean, he can, he has adjustment to say what is right and what is wrong. This is the major issue to decide what is the real judgment, who has judgment. But this is the basic thing that we have to know. If the patient, we think that he can make his own decisions. I mean, he doesn't think that someone poisoned his food and therefore he must die. He doesn't think that the devil is going after him and therefore he should die. If a patient has judgment, so practically I can take a woman like this to the psychiatric department if she doesn't want to be treated. If she wants to be treated, I can talk with her and convince her to come to the department, she can come. But if she doesn't want to come, then I must release her from the hospital. I can't hospitalize her if she doesn't want to come. In this case, just to tell you that I convinced the patient to be treated by the psycho-oncology unit at Hadassah, and she went home. She didn't want to come to get hospitalized in our department. And 3 days afterwards, her son called me and told me, well, we couldn't save her, and she committed suicide 2 days after I discharged her. But I have no choice. I mean, we have some regulatory things that we have to obey. We cannot hospitalize everyone. We can really try to convince the patient and the family to be hospitalized. And I think that in discussion of the autonomy, the rules for deciding who can make a decision, from my point of view, is an important example and could be used in other disciplines.
I wish you'd be asking easier questions.
Life is tough, and dying is even tougher.
I'm on the spot. I just want to come back to connect this to where I come from, and it's hard for me to connect to the debate you've been having here for a couple of years and what is at stake. From where I come from, I think I reflect a lot of people's opinion about this, is that I feel quite uncomfortable if life is being dismissed, if we respect people's autonomy, but the value of life is really taken lightly. But I think, even more uncomfortable if we impose the value of life on an individual. So I guess, in the general scheme of things, I'm slightly more on the side of autonomy, likely because I view human life as being inherently subjective. A human life is a life that is lived by one single individual. But that being said, even in a fairly liberal country as mine, we live in a society, and when we make these decisions, others are involved, and society is involved. And that puts different constraints that vary. And even though we're talking about a very general perspective on these issues, they vary across countries. And in our case, the clinicians' ethos, the values of clinicians and their role will be an additional check on the process. I mean, clinicians are not obligated to, first they need to respect refusal of treatment. They also they're not obligated to act in ways where they don't see any clinical meaning. So for example, the case of brain death, if there's no clinically meaningful outcome to be pursued, they are not obligated. And if I take that to a systems level in our healthcare system, I think there are some lessons, because we have a healthcare system based on solidarity. And of course, our resources will always be limited. That doesn't mean that we can impose, very crude forms of euthanasia and so forth on people. But I think there is a wisdom there that is, for our society at the systems level, it needs to percolate everywhere. It needs to be in everybody's mind. If I use resources, it is for what and for which purpose? Do I really want this? And by doing so, am I having an impact on others? So I think even within a very liberal framework, we are involving others in these decisions. They may not agree with them. In the case of euthanasia, we're just starting a debate in our country. The Quebec College of Physicians emitted survey data showing that physicians tend to be slightly in favor of euthanasia. But this is a debate. It's just opening up. It will involve the clinicians at us as one check, and also a systems level check also.
Thank you.
Well, first let me say that I think we still need sessions like this. And I think so because this is not only an ethical issue, it is also embedded very deeply in cultural background. And based on the culture I grew up in, I tend slightly towards the value of life. And then the question is, what is life? So I would put brain death as a criterion in the value of life, because I don't think that an individual who is under brain death is cognitively aware of whether they are alive or not. But that's my inclination. I respect the fact that in other cultures people may think differently. That's everything I could say.
So let me tell you what we came up with here with the legislation. We tried to go forward with the autonomy notion, but set limits. The question was, where and why do you set those limits? And why some cultures go a little further with autonomy and some a little less? What is the basis for it? And what we felt was that the balancing power between life and autonomy is, as Professor Sorek said, is a very culturally, it's a cultural matter more than philosophy that you can substantiate. I mean, we can't argue. I mean, I can feel very strongly for life. You can feel very strongly for autonomy. I can't convince you. You can't convince me. So we need to find a balancing power within the culture. And our feeling was that the Israeli culture is very much for life. We do extreme things to go far away and spend so much money for a very expensive operation to save life, which the chances are very slim, which in most Western societies they wouldn't even consider, on a personal level, not only from the country part. We are involved in a lot of, I call it scandals, of organ trade, because Jewish people like to live, and they do even some things which are wrong ethically just in order to stay alive. So life is a very important principle in Jewish and Israeli sphere. Autonomy has become, over the years, a very important principle. As we heard, until about 30, 40 years ago, autonomy was a non-issue. Paternalism was for 2,500 years the prevailing system, and today it's a dirty word to say paternalism. I'm not so sure that it is right. There are some paternalistic approaches which are important even today, and autonomy, I think, swung too far out in the regular sense of, so if it comes against life, it becomes problematic. So we decided in the Israeli law to go on some balance, which not everyone would agree, but we got a wide consensus. And that is that a person cannot request, he can request, but he will not get an active euthanasia, no physician-assisted suicide. In other words, an act that hastens death on intention is opposed to the value of life in such a way that it overrides the autonomous wishes of the patient, because, as you said, we have a solidarity. We have a society that has values, and everyone in the society pays a certain respect and a certain price of his individual values for the good of the society. If everyone would do whatever he wants, that's anarchy. And no society wants to go into an anarchy. So society makes a framework. The best example, I think it's everywhere in the world, that you must wear seat belts. And if you don't wear them, you get fined. What do you mean? I am an autonomous agent. I want to drive without a seat belt. What do you care what will happen to me? Who are you to tell me that I must wear it because if there will be a car accident, I'll get less hurt if I have it? Who are you to me? I don't want to have it. So society imposes on your autonomy and says, for the good of the norms of society, you shouldn't be injured too much. Yes, we care for you. So we take away some of the autonomy. So therefore, if someone wants to do an active act, either he himself or with a help, that will kill him unrelated to his illness, active euthanasia and physician-assisted suicide is killing the person at a time where from his illness he will not die yet. So that is forbidden. We also set a limit between omission and commission, which is a very debatable matter in ethics today, whether there is a difference between omission and commission or not. We felt there is such a difference, and therefore the bottom line is that autonomy is respected as much as the patient requests to omit further treatment. And then he'll die of his illness with all the support that he needs, including pain relief and social, and that is covered by law. It has to be paid, not like in England. That in Israel has to be paid. Everyone who is living because we want him to live, because we didn't go with his autonomous wishes to die, at least he shouldn't suffer. So we pay for it. But commission, to do an act that hastens death, that is not allowed by law. So this is where we drew the line between omission and commission. Omission, autonomy; commission, life. That's in broad sentence. Any comments from the audience? Yes.
Mike? Okay, without the mic. You talk a lot about permission and so forth. What about the using a holistic approach which takes into account the quality of life and prolonging life? You mentioned that if someone has 6 months to live, give them that 6 months. But isn't it true that in Israel, and as well as in other countries, people lose 10, 20 or more years of their life because of ecological factors, asbestos in Nahariya, soil pollution, water pollution, air pollution? I mean, the amount of air pollution in some areas is so great that it's the highest in the Western world. That certainly reduces life expectancy by 10 or 20 years in certain areas.
Well, you're certainly correct with your comment, but it's unrelated to what we are dealing now, and I can talk to you privately. So I think we touched only 2 issues. I'll give you some homework to think about it at home. And the third question that I intended to raise is, who makes the final decision? So if the person is autonomous at the time where the decision has to be done, then he takes preference over most others. But what about all the neurodegenerative diseases where the person is not competent? And even if he was competent, we don't know for sure what he would have wanted in this condition. Who makes decisions on his behalf? And think about it, because family has problems, physicians have problems, the clergy has problems, the legislator has problems, and it is a very complicated matter. And by the way, most of the dying patients, unless it's an instant death of a car accident or heart attack, die incompetent today. So who makes the decision? Think about it.
Thank you very much. I will take one decision. First, I will take the decision to thank all the panel, all the speakers. Okay? I believe, it's very pity because I believe that this presentation, in a discussion like that, we should laugh in all auditorium here. This is a so important issue and so important thing. But this is only the beginning, so we will continue with this symposium. We want then to thank all the people of the ERANET that came here and make us to be part of their group and be together. Thank you very much, all the audience, and we hope to see you again in Israel. English.